afternoon, good evening, colleagues. Welcome to this session. It's about accelerating primary healthcare transformation with evidence. I know this is the last hours of a very packed day, the first day of the World Health Assembly 77, 2024, but I believe you have come to this room with energy and with to speak about primary health care. So, distinguished delegates, honorable ministers, dear regional directors, dear ADG, colleagues, friends, I open this side event on primary health care, and we will be here with you for the next at least 1.5 hours. So in this side event, we're not going to talk about what is primary healthcare approach. We are not going to talk about why primary healthcare approach. No, we are here to talk about the how. How is primary healthcare approach is implemented? What have we learned? How we have learned? How it looks like in real life? And how we can come together to share, to move faster and smarter together on PHC approach toward universal health coverage. So that's why we are here today. The event has 3 segments. The first segment is about setting the scene. It's about remarks. And it's about learning. It's about hearing the big vision globally and regionally and country-wise. The second segment is about learning. It's about evidence. It's about sharing with you the PHC primer, implementing the PHC approach. It's about learning, the knowledge management, and the cross-country learning, the knowledge management, the political momentum, and the partnership on primary health care. And the following segment is an interactive segment about countries' prioritization. It's about what is the priority when it comes to learning on primary health care approach. It's about what you need, what countries need to share, and what countries need to learn, again, to chalk out a joint, smarter, and faster plan together for primary health care approach towards universal health coverage. So this is a hybrid event. We have more than 2,000 people registered. We had to close the registration really late because there was so many interest, and we really encouraged people to join in. At this moment, as I speak, we have more than 300 people logged in. So people are also listening to this event. And we have interpretation in 2 languages, in Spanish and in Russian. So with that opening, I would like to invite our key speakers for the first segment to kindly come to the floor, on the stage. Dr. Bruce Aylward, Assistant Director General, Universal Health Coverage and Life Course. Regional Director, Dr. Hans Klug. Please, we have a small stair there at the left. You can sit anywhere, exactly. Excellent. And Dr. Jarbas Barbosa, please. It's so great to have you. And Dr. Rana Haji, Director, Program Management for Eastern Mediterranean region. So this is very good. Thank you so much for being with us tonight. I would also like to acknowledge the ambassadors who are here, the permanent missions, attaches and representatives who are here. Thank you so much. This is how we can make a change together. So I would like to invite Dr. Bruce Aylward, Assistant Director General, to give his opening remarks.
going to stand up and speak from here, if that's okay. First of all, for those of you who have a written version of the program that says Dr. Tedros is giving opening remarks, don't worry, you're in the right place. But as you know, Dr. Tedros has had to be cloned for the World Health Assembly per usual, and I'm one of the clones that get to say a few words on his behalf. For those of you who don't know me, I'm Bruce Aylward. I'm the Assistant Director General for our work on universal health coverage, which includes, of course, our work on primary healthcare, the primary healthcare approach. And excellencies, regional directors, colleagues, ambassadors, friends, I'm absolutely delighted to have a chance to open this event and kick us off today. I'm going to be brief because we have to get to the evidence. And also, Dr. Tedros has cloned me not just for this meeting, but for a couple of others this evening. So I'm going to move us along. But I did think this was such an important part of what we're trying to do in the global health agenda. I wanted to be sure we had an opportunity to participate at the beginning and at least to kick us off and get us started. And I want to first pay tribute to Spain and Kazakhstan, who are hosting us here today, two of the great pillars in primary healthcare who I've learned so much from. I'm sure many of you have as well. It's so fitting that you're here. And folks, as we kick off today, I want to just remind us we are in a very trying time geopolitically in the world. There's a lot of division in the world, a lot of tension in the world right now, a lot of challenges we're dealing with in the world. The world doesn't agree on a lot right now, but one thing it does agree on is the primary healthcare approach is key to what we're trying to do on our journey toward universal health coverage and some degree of equity in this world, the world that came out of the pandemic so recently, where we didn't see, quite frankly, a lot of equity. So this is one thing we do agree on. And it was exactly 1 year ago that we met here at the Assembly, and you, our member states, and many of our partners behind them said, we unanimously agree we need a primary healthcare approach to reorient our health systems if we're really going to make progress on universal health coverage and sure people everywhere get the basics at prices and costs, of course, that they can afford. And folks, 1 year ago, well, a few months after that, I should say, we launched the Global Monitoring Report, which is sort of the global scorecard. Where are we on universal health coverage? How important is this primary healthcare approach? And as you saw on that report card, we did pretty poorly. It was a failing grade. 4.5 billion people on this planet don't have access to the most basic health services. And of those that do try to access services, 2 billion suffer financial hardship. This is shameful. And that is what makes this approach and the promise of this approach so important. Because when you dig into those statistics, which sound so horrible, and they are in terms of the people who don't have access, if you look into the detail, and we'll talk about some of that tonight, there's 30% of the countries actually did make progress during this period on those two big elements of UHC that we talked about. And anchoring and common across so many of them was a primary healthcare approach. And again, I want to pay tribute to Kazakhstan, who 50 years ago almost embarked us on this journey, to Spain, which has done so much to set up really quite a model system. I was just discussing with the minister during the pandemic. I had the honor to work with Spain. I was there right in the early months at the peak of the pandemic, and to see the robustness of that primary healthcare system, the importance it was playing even in such a trying time. Again, a lot of lessons to learn. So, folks, we will get to the lessons, and we're going to jump to that in our next session. But I want to give away, three of the big ones I take away from this first year I've spent in this new role, heading up our universal health coverage work and our work on primary healthcare. And if there's three big things we've learned in the last year, as we've really dug into some of the studies we'll talk about today, the first thing is it works. Countries that have embarked on this, reoriented their systems, they are not only getting better health outcomes at better cost, their people are happier with what they're getting as well. So it works. The second thing we've learned is it doesn't work without the political leadership. And having the ministers here today, the leadership behind those ministers is really the key to making this work. And political leadership, not just at the top level, but also at those subnational levels that really have to make this happen. And the last thing we've learned, of course, is it's got to be integrated, all three dimensions, which we'll get into later today. Now, on our part, the World Health Organization, as you've seen, we've just launched. Well, we're in the middle of our discussion. I have to be careful. I don't want to jinx it at the World Health Assembly on our new global strategy. And if you look at that strategy, right at the center of the strategy, your strategy, our member states, our partners, if you look at right at the center of that, it talks about reorienting health systems to a primary healthcare approach to accelerate what we're doing on UHC. So we're rolling that out. We're going to live that over the next 4 years. We have got a physical presence on the ground in over 150 countries, and we've got UHC policy advisors in over 120 of those to help move it. So we are committed. We will help. We will take the lessons we'll discuss tonight and try and translate those into better health outcomes for people everywhere. So thank you for a chance to kick this off. Thank you so much for coming this evening and looking forward to the discussion.
Great, great. So these words, these statistics will remain with us tonight, the week, and the whole year. When we speak about primary health care, we automatically think about the famous declaration of Alma-Ata and the Declaration of Astana. Kazakhstan is the birthplace of primary health care. So with that note, I would like to invite Dr. Hans Klug, the Regional Director for WHO Euro, to take the floor, one of the leaders and pioneers in primary health care. Dr. Klug, the floor is yours.
Thank you very much, Dr. Surya, and thank you very much, Bruce. You're a very good clone. Well, I was a little bit confused. You told you was not going to be long. So my principle is I never promise that I'm going to be short. Karlikun, buen dia. Good day. Deep thanks to the leadership of Kazakhstan and Spain in bringing us together here today to celebrate and to strengthen our collective commitment to primary healthcare. Particularly as a family physician myself, this is very, very inspiring to see you here. It's also the centerpiece of our health agenda in Europe and Central Asia. I call it, as Melita and Natasha know, my flagship of the flagships. Kazakhstan and Spain, 2 of our 53 WHO European member states, have been flying the PHC flag very high, globally and very important at home, decade after decade, stretching back nearly half a century to Alma-Ata in 1978. Unfortunately, over the weekend, we lost the father of the Alma-Ata Declaration, Professor Torgildy Sharmanov, and I sent a letter to the president to convey our condolences, but it's up to us now to continue his legacy. I am ever so grateful for the partnership, your partnership in jointly hosting the primary healthcare demonstration platforms to showcase well-performing PHC for the benefit of other countries in our region and around the world. I myself, I went to Kazakhstan to open the first PHC demonstration platform, then to northern Sweden, and 3rd of June we go with my friend Minister of Health of Spain to open in Madrid, the third one. Dear friends, the role of PHC has never been more crucial. The latest WHO report on UHC reveals an alarming picture. Since the launch of the Sustainable Development Goals in 2015, the expansion of health service coverage has actually stalled. And for many who receive health services, financial protection has worsened. Based on the most up-to-date data, as of 2021, year 2 of the COVID-19 pandemic, half the world's population, 4.5 billion people, was not covered by essential health services. And in 2019, even before the pandemic, about 2 billion people, almost a quarter of our fellow human beings, experienced financial hardship due to out-of-pocket spending on health, including 344 million people living in extreme poverty. We simply cannot address this sobering reality by just building hospitals or acquiring sophisticated diagnostics. If you are to make genuine progress towards UHC, we need better PHC. And for this, visionary leadership is key. I have long said that health is a political choice. By extension, UHC is a political choice. Reaching the goal of UHC by the SDGs finish line of 2030 requires commitment by governments and policymakers to invest substantially in the wider public sector ecosystem within which health is situated. Investments based on solid evidence to help reorient health systems through a primary healthcare approach. Science and evidence-based technical support for better political decisions on health underpins the WHO mandate of Health for All. To this end, I salute the PHC primer we are celebrating today, which consolidates global evidence on PHC transformation, which actually fills a significant vacuum in our policy toolbox. Dr. Vestna, the chair of the EB, told me even this morning, Hans, we waited from you this so long, in more straightforward terms. Member states have long clamored for evidence to garner the political support necessary for PHC investments. This primer synthesizes evidence on a range of policy-relevant questions to guide the transformation of PHC, on the effectiveness of different models of care, including telehealth solutions, tailoring services to urban and mountainous populations, using big data and AI solutions to identify and reach the vulnerable. But the evidence we've gathered will only remain words without committed political leadership across our member states to convert them into action. I always say, what is public health? Public health basically is the mixture of health and politics. You have to identify what to do, how to do it, and most important, then do it. And this brings us to the second launch of today, the PHC Coalition of Countries, a platform for cross-country exchange and co-creation. I applaud this member state-led initiative, which Dr. Tedros and me discussed with the president of Kazakhstan, President Tokayev, at the 45th anniversary conference in Astana. And it will strengthen all our efforts, the WHO efforts in supporting the countries, providing motivation, advocacy, and lesson sharing, learning what works and what does not work. We have long known the benefits of investing in PHC. It is just the most cost-effective way to foster prevention, helping to curb long-term expenses and strengthening overall public health. Despite the evidence, PHC often remains overlooked today in favor of high-tech medical advancements that by themselves cannot benefit entire populations without a foundation led by primary healthcare. And one does not exclude the other one. So I strongly urge the PHC coalition of countries to turn this around, to advocate for reframing health systems through a PHC lens, and truly ensure PHC is given the priority it deserves. This is not just a choice. My friends, it is a moral obligation, a prerequisite for the societies we aspire to be. Societies grounded in trust, in empathy, where health and happiness flourish for all. Rahmet, gracias, thank you.
Health is a political choice. UHC is a political choice. PHC is a political choice. And PHC is imperative. Thank you so much for reminding us of those facts. What makes the political choices happen? One of those prerequisites are evidences, or data, or the science of the PHC, how it works and how it looks like in real life. So with that, I would like to invite Dr. Jarbas Barbosa from PAHO, director from PAHO. Americas have been the champion and the front runner of the primary healthcare historically. There are many good, profound, sound examples in the Americas when it comes to the primary healthcare implementation. Dr. Barbosa, so glad to have you. Thank you. The floor is yours.
Thank you. Good afternoon. I'll be short too. First, I want to to thank the organizer of this event, the government of Spain and Kazakhstan, the observatory. I think that is really a very important moment to have all these people here together discussing what we call in the Americas the renewed and the strengthened primary healthcare. Primary healthcare as the backbone of a resilient health system and as the main important platform to deliver not only health care, but also health promotion, prevention, the first line to respond to pandemics and many important things. Countries in the Americas are moving very quickly to strengthen capacities and expand the health systems on the PHC approach in the post-pandemic era. Some examples are from the universalization of access to primary healthcare in Chile, that have started with some municipalities, and they are aiming to achieve 50% of all municipalities in Chile by the end of this year. The increase and improvement of financing for primary healthcare in Brazil, new investments in Guyana, important expansion of primary healthcare workforce in Colombia. Our countries recognize there is an urgent and imperative need for action. Primary health care is the foundation on which we can recover lost public health gains that were very important effect during the pandemic in the Americas, for instance. Maternal mortality, that may be the best indicator of access and quality of care, increased 100%. We went back 2 decades on maternal mortality in the most vulnerable countries in Latin America and the Caribbean. It's also important to ensure universal access to health and universal health coverage, and prepare and respond against public health emergencies. Last December, we convened our member states and key strategic partners to address the urgent need to accelerate the transformation of the health system based on primary health care. Let me here thank Minister Karina Randall, a good friend that will address this meeting in the next panel, for hosting the International Forum on Primary Healthcare in Montevideo, Uruguay, and supporting the launch of the Primary Healthcare Alliance in the Americas. This alliance, which brings together PAHO, member states, the World Bank, and the Inter-American Development Bank, is working around the 3 critical pillars for health systems transformation and accelerated actions. Firstly, in investment, promoting joint work in health, finance, and economics, bringing health, finance, and social protection sectors together to increase and improve health financing, addressing persistent inequalities. I think that we live, at least in the Americas, a unique moment. For the first time in many decades, PAHO, the World Bank, and the IDB are recognizing that we needed to use the $2.2 billion in loans that the countries in the Americas mobilizing in the last 3 years, not only to build new hospitals and the expensive equipment, but to strengthen primary health care with a comprehensive package of renovating, retrofitting the facilities, but also digital transformation, telehealth, training of the healthcare workforce in order to have primary health care that can address the complex epidemiological scenario that you have in Latin America and the Caribbean, the persistence of communicable diseases, the preventable deaths related to non-communicable diseases that we estimate around 34% if they could be diagnosed and had access to treatment before the first stroke that a person has, and the other things. So we are working together. We have many member states that have already joined and have asked PAHO, the World Bank, and the IDB to have a mission to the countries. And I think that this will be a very important opportunity for the next years to change the way that the primary health care has been delivered. Secondly, in innovation is the second pillar. Leveraging digital health in primary health care, in innovation in pharmaceutical technologies, and in workforce organization and private sector engagement. We do believe that when we are talking about digital transformation, we are not talking only about the electronic records, of course, that they are very important, but also how we can use it. And we developed some packages to support the countries, including the hardware, the software, training protocols, in order to to guarantee that the populations living in remote areas can have better access to primary health care. And thirdly, implementation. To move from theory to practice, to walk the talk on primary health care too. Yesterday we walked the talk on health promotion, but we need also to walk the talk on primary health care. At the national and subnational levels, expanding the health service delivery, especially for underserved and remote areas, and for population in vulnerability. People live in the slums in the big cities in Latin America, indigenous populations, and other people in situations of vulnerability, based on needs and evidence. This alliance jointly with the other new strategic partnerships developed over the last year is leveraging increasing capacity in technical support to our countries. Distinguished colleagues, we will continue to advocate with our political leaders in the Americas to accelerate the health system transformation based on primary health care. I think that more and more countries and leaders and ministers of health and heads of states are understanding that maybe one of the most important ways to provide a more effective use of the limited resources that they have is to strengthen, to renew primary health care. And we will work in every corner of the Americas collectively with our partners to ensure that everyone, everywhere, can address their health needs through health systems built on the strong foundation of primary health care. Thank you.
Thank you. Thank you, Dr. Barbosa. It's time to action, walk the talk, innovative solutions, digital investment in primary health care. And very importantly, you reminded us that it's a call from member states. It's a call from national and sub-national authorities. It's a call from people. Great, it's imperative. So our last speaker in the first segment, but of course not least, is Dr. Rana Haji, Director Program Management from Eastern Mediterranean region. Thank you, Dr. Rana.
It's great. Thank you very much, Soraya, for organizing this. Greetings, colleagues. Assalamu alaikum, as we say in our region. Salam, buenas noches, hola. So much for convening us here, and I'm really very happy to speak on behalf of my region and my regional director, Dr. Hanan Balkhi, who couldn't be with us. Of course, I don't need to tell this crowd about the importance of primary health care. I think everybody recognizes how critical primary health care is, how important for universal health coverage, and what a major right is for everyone. We just kicked off today the World Health Assembly. I'm looking at Bruce and I see he left already. And the slogan of the World Health Assembly this year is health for all for health. So actually, we are all in this together. We're gonna need the support from so many partners and so many countries around the world to make sure that everybody has access to the critical services. I would like to address a couple of key issues for us. First, our regional context, and also the main topic, which is why is data or are data more important. Of course, I come from a very diverse region, the Eastern Mediterranean region, which covers 22 countries or 21 countries, plus the occupied Palestinian territories. Very rich, as we like to call it, in its culture and its diversity and its history. But unfortunately, it's a region that's plagued by emergencies. And delivering healthcare in emergencies has been really one of our, oh, I hope they were hearing me before. Okay. Great, thank you. So delivering healthcare in emergencies is a completely different ballgame. Right now, I call it, maybe with reference to one of my favorite authors, it's like love in the time of cholera. It's health in the time of emergencies. We have to continue. We have to continue delivering. We always, as we say at WHO, we stay and serve in the middle of all emergencies. Right now we are facing some of the largest crises in the world, with the crisis in Gaza, in Palestine, as well as the crisis in Sudan. where 6 million, over 6 million people have been displaced. And we have that impossible task of ensuring that we are delivering healthcare to people in these two countries. Also, we have seen, however, major commitment in our region from all of our member states. In 2008, 30 years after the Alma-Ata, our member states convened in Qatar and they issued the WHA Declaration, which was basically renewing the commitment to primary health care. Just before COVID in 2018, we had another major meeting for all our member states in Salalah in Oman, beautiful part of Oman, and they issued again the Salalah Declaration, which is focusing on universal health coverage, but nonetheless, on the importance of strengthening primary health care. Nonetheless, right now, the delivery of primary healthcare, the implementation of primary healthcare is still suffering from major challenges. And the last data shows that our major indicators, whether it's our coverage index, which is about 57, around 11 on the average, around 11 points less than the global average. Our out-of-pocket also indicators show almost 1 in 8 in our region suffer from, or can face poverty because of medical expenses. So we are far behind. I just want to, though, say that this doesn't mean it's all doom and gloom. We have many countries in our region that had done great in terms of improving their primary health coverage, and that's why we have a huge diversity. In 2019, and with support from the Gates Foundation and with many of our other sister agencies, UNICEF, UNFPA, UNAIDS, as well as WHA, we actually launched a major initiative called the Primary Healthcare Measurement and Impact, PHCMI, which was very important for us to identify where are the gaps in data. And what this initiative found is that we have major data gaps in primary healthcare and the need to have stronger integrated health information systems. There are areas where, for example, some weaknesses like outdated clinical guidance. I mean, there are lots of areas, even though they did indicate that actually we do have some areas of strength, such as the importance of policies. So the major needs rely into basically taking these policies and translating them into action. So as you mentioned, Soraya, I think it's the time for us to move into action. During COVID, we learned the importance, again, of primary health care and the importance of data. If you recall, within the first year of COVID, there was a major survey looking at continuity of essential services that showed that most countries have suffered significant decline in essential health services. But it only took a few months later. The second survey immediately shows, some improvement. And the third survey showed even more improvement. In the middle of a major pandemic that really grabbed the whole world by surprise, we were able to conduct surveys and to actually use the data from these surveys to improve the delivery of primary healthcare services. So where do we go from now? What do we need? What we need is, again, the re-emphasis on the basics, what I say. The focus, again, on delivering primary healthcare. I join all my esteemed colleagues, regional directors, in their call for putting, again, the focus on stronger systems. Without stronger systems, we cannot have good delivery of healthcare systems. Without stronger information systems, we cannot collect data and actually act on it. And maybe I was inspired by Hans' comments also about health being a political choice. And peace is also a political choice. Without peace, we cannot have health, unfortunately. And our region just last year also launched a major initiative, which is actually Health for Peace, that is going to be discussed as well at the World Health Assembly this year. And I hope that health and peace will prevail in our region all over the world. And I look forward to really seeing more data. Thank you for the compendium, Soraya and the team. We would love to hear more examples about how can we better learn from examples in other countries. How can we better engage the private sector, which is taking increasingly more and more of primary healthcare in our region, and how can we really deliver, continue to deliver, stay and deliver even in the middle of the toughest situations anywhere in the world. So thank you again very much for the chance to be part of this panel. Thank you all for your engagement. Rahmat and muchas gracias.
Shukran. Shukran, Dr. Haji. Okay, we have heard important points. Health is a political choice. UHC is a political choice. PHC is a political choice. Peace is a political choice. Health for all for health, and health for all also means health in unstable, fragile, and conflict situations. We have heard that half of the world population do not have access to essential health services. This is a very, very bold and dark figure. We have heard that political declarations, regional level, exist on UHC and PHC. We have heard about innovation, digital technology, importance of information system and health system as a whole. Health system is the key, is critical in this endeavor. Walk the talk. PHC is imperative. So you have really laid the road to the next segment, which is about evidence. What evidence tells us? Where are those evidences? How we can generate learning, sharing. It's a shared agenda, whether we are in the north, whether we are in the south, in the east, or in the west. PHC is relevant in all socioeconomic contexts. Why? Because right to health is universal, because equity is a universal principle, because solidarity is a universal principle, because community engagement, people, society, families, citizens are a key ingredients in our actions. So with that, I give the floor to our next moderator, Dr. Melita Yakab, to walk us through. Thank you. Thank you very much. A big...
Thank you very much, Soraya. Let's give a big hand to this first panel. And I'd like to ask you to navigate this tricky podium and go back to your place. All right, it's big gymnastics here in the front, trust me. And when that's happened, I'd like to invite the panelists of this second segment to again navigate this complex gymnastics and take your seats on the podium. I will introduce our panelists when I give them the floor. So if I may ask you to please come up, take your seats. Shams, please. We accomplished, I think, the hardest part of this part of the segment, and I'm really delighted that you're all healthily sitting up here. And in this segment, I would like you to think about two questions, but not just our panelists. I would also like you in the audience to think about this. I would love to hear your views. And those of you online, you have an easy way to share your views. Please use the chat. Tell us what you think. And question number one, we used the word evidence so much. Do we think we now have the evidence we want to have for primary healthcare transformation? And especially you in the frontline policymakers making decisions about primary healthcare, do you have the evidence you want? And the second question I would like us to think about is evidence is not enough, right? What mechanisms do we have to leverage this evidence, to use this evidence, to put it to action? And without much ado, I would like to invite our first panelist, Deepa Rajan from the European Observatory, to give us a bit of an overview of the primer which we're launching today. And what do you think, Deepa, about does the primer answer all the questions we would like to know about primary healthcare?
Okay, thanks, Melita. And the short answer is almost.
Okay.
So I'm going to introduce this book to you. It's all, you've seen it in the front when coming in, and I'll be quite quick since we are a little bit over time. But let's start with the title, Implementing the Primary Healthcare Approach, a Primer. What do we mean by that? A primer, because we want to prime you, our readers, into all things primary healthcare. We want to bring together the global evidence, the what, and especially the how, but also the impact that primary healthcare can have and has on health systems performance. The second title to this publication is the Global Report on Primary Healthcare. This is a joint publication between us at the European Observatory and the World Health Organization. So let's dive right into it. The objectives of this is in line with what I just said, is looking at a common understanding of PHC. So really that what piece, that's the part one of this report, which has 3 parts. Then the bulk of this publication is really on the how. So what are those strategies and actions that have taken place in countries that are documented, where we can learn from, that really push a health system towards a stronger primary health care? What are those common enablers and barriers? And then finally, we really would like to understand, what does the literature say about the impact of doing primary healthcare, of really pushing for a primary healthcare approach, to really invest in primary healthcare? What does the literature say in terms of the impact that has on those health system goals that are important to us, like reducing morbidity and mortality, like increasing health equity, etc.? So that impact piece is the part 3 of the book. So our methodology was literature reviews. This is about evidence. So we had over 70 authors, a great group of authors from all around the world who had content-specific expertise, geographical expertise, to really tease out those key lessons. And we looked at not only the peer-reviewed literature, but also the gray literature, because we know that some of those country efforts and country implementation documentation is not in the peer-reviewed literature. It's in those ministerial reports. It's in those country case studies. It's in international organization reports. So we really mine those to understand what's going on in countries, what is happening in terms of implementation. So I'd like to also make reference to the country case study compendium, which my colleague Faraz will be presenting in a bit. This was a gold mine for us, because it had over 250 case studies from countries all around the world to really help us understand what are the contextual drivers, the enablers, the barriers to really make primary healthcare work. What are those policy changes that support pathways towards PHC, and also which ones are transferable to other countries? And finally, I'd like to just draw attention to these 3 parts. Again, you have part 1, which is about the what, which you'll see in the chapter list. You have the historical overview, definitions, concepts, etc., so that we have that common understanding. And then the bulk of this book is really this part 2. What are those health governance arrangements, workforce arrangements, financing arrangements that make PHC happen? This is the overview of the evidence. And then, of course, part 3 is looking at what does the literature say about PHC's impact on equity, efficiency, quality of care, resilience, those really important health system goals that we wish to reach. And then finally, I'd like to draw attention to, there we go, to an article that just went online this weekend in The Lancet, drawn from this publication, the Primary Healthcare Primer, where we go into, amongst other things, some of those really key evidence pieces. And you can see here that, yes, PHC does move us towards more equity, more efficiency, resilience, better quality of care. And the details of those, of that evidence review is in the book. You can also get it digitally through this QR code. Thank you very much.
Thank you very, very much, Deepa. What a tour de force, isn't it? What a gold mine. Let's put our hands together for those 70 authors who worked for years to put this evidence review together for us so that we can put it to good use to change policies. A big bravo. And now I would like to introduce my colleague, Faraz Khalid, who is research officer in WHO. Deepa already mentioned this compendium of case studies, and it's really fantastic that we have global evidence review, but country-level narratives are critically important to inspire change in other countries. Please tell us about this, as well as tell us a little bit more what mechanisms we are beginning to work on to leverage this evidence and make sure it gets into the hands of those who can use it.
Thank you, Marita. Good afternoon, early good evening, everyone. So as Deepa mentioned about the primer, the global publication, many of you may have scanned the QR code. Some of you may have already picked the book or the summary outline out, summary lying there out the tables. The primer delves into more than 50 country case studies in detail, right? But it's already more than 450-page document, right? So given the expanse of the primer, all country case studies could not have been captured. And by the way, by no means we are saying the evidence captured in primer is something which speaks to all the countries where the primary healthcare transformations are happening. And hence, when you just type in any browser, not advocating only for Google, but let's say for now, you only say PHC country cases, 3 things come up. One is it says that in 2019, there was a resolution which calls to improve the exchange of country experiences for PHC implementation. That's the first thing it pops up. Then also there is a lever of PHC operational framework, which emphasizes that these country cases are a priority for PHC-oriented research in the operational framework, but also it asks you where to find them. So there's wealth of country experience, which does not find the way to indexed peer-reviewed journals. So where does it situate? And here is a potential offer. So in the background, you see bulk of country cases coming up, but where you can find a search PHC case study search engine. And it's a web-based repository today, which we are launching already. I'm usually not good at clicking, and I often struggle when I'm on the podium for clicking and hope it helps. Here you go. So this primary healthcare case study compendium, as I said first, to serve as a global hub for searching and accessing PHC country case studies. What it includes, currently it is a database of more than 200 case studies published by WHO and partners, 100 more to be uploaded in the coming 4 to 6 weeks, where you can find it's housed on the WHO page on primary healthcare. And a range of filters are available to capture these case studies, but also to search them. And in the next, here you go. So you can search by some of the keywords which are present on these filters, either when you're looking for a certain country, you're looking for the income group for a certain region, certain operational framework lever, either strategic or operational, but also with regards to different health programs. And you can play with the mix of such filters. And here is an example from one of those case studies which have been tagged using these filters. So basically, it's a simple web-based repository to look for country case studies which you may not find in index peer-reviewed literature. And it would be a living repository. So that's the first thing. But the second thing, moving from here, well, Melita posed the question to me like, okay, we have a primer, we have this big case study compendium, a living repository. But is this all enough for us to institutionalize change on ground? For our policymakers, when they leave this room, we hand them over a 450-page document with this living repository. Can we expect them to immediately start using as they go back? And here is another offer, another product, which is again coming from the WHO resolution, which asks WHO to develop such institutional capacities within the organization, but also within member states, how they can implement primary healthcare reforms. And the offer is this Strengthening Primary Healthcare Leadership, a global capacity building course. I've already explained the why of it, to equip the key policymakers, leaders. And for this course, in its first iterations, we will be targeting more senior policymakers of working at national, subnational level. who can influence the PHC agenda, either its development, implementation, and evaluation moving forward, but also how we can equip them with the baseline knowledge, that understanding the basic idea around primary healthcare, the operational levers to implement it, and also exhibiting leadership around it. And this course would be a blended course with synchronous and asynchronous sessions. I won't bore you with all the slides listed here, information listed here, starting with why primary healthcare, how it could be people-driven transformation, the three components of PHC approach. And I'll spend last 30 seconds on this, leading change, which is fundamentally important, starting with leveraging leadership, governance, and financing, how we can reorient our certain important functions where policymakers have to make certain choices. Let's say if you talk about health workforce, there's a big agenda around health workforce, but when you have to reorient and reprioritize which cadres to support and institutionalize, it's a policy choice. Similarly, when you have to shift the financing from urban high-end care versus rural first level of care, and that such decisions, they go on and on. So how to equip them navigating the politics of the change? And the course ends with leading with compassion. We're really bringing back this value that PHC is all about people. PHC is about empathy and how compassionate leadership can drive that. With this, I think we have come to the three products: a primer, a case study compendium, and a leadership course, so that people, when they leave room, they feel they have not only some books to carry, but also some more things to come up, which can help them transform the PHC agenda. Back to you, Marita. Thank you for your patience.
Thank you. Thank you. Thank you very much, Faraz. And I love the complementarity of these products. And I remember when we started working on the global course years ago, we actually did get stuck at the beginning because we didn't have the global evidence. And without that, we were shooting in the dark, like many of you making policy changes, shooting in the dark if this evidence is not there and not available. And I believe we can really leverage these knowledge products really well through the global course. But we'd love to know how our member states think about this. And I am honored to introduce Minister Monica Garcia, Minister of Health of Spain. And how do you feel about these products from the perspective of member states? Are they useful to you? Would you use them? And what are you doing as a member state to leverage knowledge and make change happen?
Thank you very much, Melita. We know we have a lot of evidence that primary care is essential to ensure the right to health protection for the population. And we know we have evidence that it plays a crucial role in overall well-being, as well as in providing comprehensive and equitable care. Primary care also contributes to sustainable healthcare system, which not only focuses on treating diseases, but also actively promotes population health. We can say, and we have evidence to say, that primary care is the best tool to make the theme health for all real. So there is no doubt that Spain is a benchmark country in primary care and serve as a model for many countries aiming to advance towards more robust and effective primary care. Numerous strengths we have in our model, in our primary care, that testify to that. So the opportunity to participate in the WHO demonstration platform is an exclusive experience of which Spain is very proud. It offers us a unique chance to share and highlight the Spanish primary care model with other countries in the WHO European region. By promoting, collaborating, and partnership among participants, this platform will not only strengthen our own improvement efforts, but also significantly contribute to the advancement of primary care regionally and globally. Spain has a solid primary care model rooted, of course, in Astana Declaration, and we have a decentralized governance model, and various initiatives in autonomous countries make it an ideal host to showcase best practice in primary care. Spain is international recognition as a leader in primary care, further underscores its sustainability to host the demonstration platform. So we have a lot of strength and some weakness. Our strengths are universality. We have recovered the universality, equity, the gratuity of services, the community orientation, the decentralization, digitalization, and a strong multidisciplinary teams are clear evidence of this leadership reflected in one of the lowest rates of unmet healthcare needs and avoidable hospital admission in the entire European Union. So the primary care model in Spain allows for comprehensive, close and continuous care for individuals, families and communities, and reaching the entire population regardless of socioeconomic status, making it fundamental for health equity and why not social equity also. However, despite these achievements, our primary care faces significant challenge. We need to make all these actions, all these things real. So we have a plan. We have a plan that was structured around lines of actions that frame the execution of projects at a regional level. This includes improving clinical management processes, expanding and renovating diagnosis equipment in health centers, temporarily incapacity development, professional training, or improving infrastructure on health centers and emergency services, all of which are consensus-based actions supported by the best available evidence. We need to continue working to strengthen the resolution capacity of primary care, to make the healthcare system more resilient and to improve population care. We know that the actions of our primary care needs to address its weaknesses and adapt to the 21st century. Are numerous and varied: accessibility, coordination between healthcare levels, bureaucratization, governance, or financing are some of them. And we would like to continue learning from other models in other countries to address this challenge. In this regard, we value the opportunity to learn from models in other countries and continue to advance towards more robust and effective primary care systems. Thank you very much.
Thank you very much. I believe this is a very important intervention, because what I'm hearing you say is that in addition to the mechanisms we're talking about, we need country-to-country exchanges. We need bilateral exchanges so that countries can learn from each other, learn from change makers who have implemented difficult changes, and learn from them how they did it. And this is what you mentioned the demonstration platforms do. This is a product that WHO Regional Office for Europe launched to organize structured country-to-country exchanges. You can pick up some brochure on your way out where it is explained how we do this. And we're extremely grateful to the 3 member states who open up their countries, their primary healthcare systems, to put them under the microscope so that others can learn from it. Kazakhstan, Spain, and Sweden. But I also know that the other WHO regions are also organizing these intensive country-to-country exchanges. And that's an important product that we all need to be mindful of and think and keep adding to our arsenal of the way of learning. Now, with that, today we're launching another mechanism to leverage evidence, and that is the Primary Healthcare Coalition of Countries. And I'm really delighted to give the floor to Dr. Timur Sultangaziev, First Vice Minister of Health of Kazakhstan. Kazakhstan floated first this idea in October at the Primary Healthcare Conference. And since then, it has gone through lots of consultations with all of you, with member states. Timur, if you could tell us a little bit more, where are we with the coalition? When is it going to be active? And what is it? And how can member states join this coalition to leverage evidence?
Thank you, Melita. First, for the memory of the Alma-Ata Declaration, for the father of the Alma-Ata Declaration, the former Minister of Health of Kazakhstan, Dr. Turegilde Sharmanov, who just passed away 2 days ago. at the age of 94 years, I would like to make a call to have a moment of silence. Thank you. I thank the organizers for the opportunity to share Kazakhstan's desire to join forces to achieve a valuable common goal. Health is a fundamental human right. Achieving the highest possible level of health is a major social goal for governments worldwide. We commit to ensuring health for all, including by strengthening primary health care. However, more than a sole commitment is needed, especially in the light of today's global challenges. It is crucial for each of us to unite an aspiration, strengthen partnership, and stimulate political momentum to achieve our common goal. Countries have recognized the importance of the primary health care for the health since 1978 from Alma-Ata Declaration. And 40 years later, in 2018, WHO members reaffirmed their commitment to the values and priorities and principles of Alma-Ata Declaration by adopting Astana Declaration. In the Astana Declaration, countries confirmed that PHC is cornerstone for the sustainable health systems for WHA and for SDG. In the light of today's global health challenges, we see an urgent need for our countries, international organizations, partners to join forces to strengthen and improve the resilience of our health systems by enhancing primary health care. WHO is already carrying out such work on the global and regional levels. For example, the European Center for PHC operating in Kazakhstan since 2015 and PHC demonstration platform operating in Kazakhstan since 2022, in Sweden since last year, and in Spain since this year provide significant support to the European region's member states in strengthening primary health care and developing human resources. Considering current challenges and global trends and striving to achieve UHC and health-related SDGs, last year on October 23rd, 23, during the global conference on PHC dedicated to the 45th anniversary of Alma-Ata Declaration and 5th anniversary of Astana Declaration, the President of the Republic of Kazakhstan, Kassym-Jomart Tokayev, presented the initiative to create a coalition of countries on primary health care and called for countries to join the coalition. Acting in accordance with the declaration of Alma-Ata and guided by the essential Astana Declaration, this coalition is committed to global reorientation of health systems toward primary health care following the PHC operational framework. In this regard, we invite interested countries to support Kazakhstan's initiative to join the global coalition of countries on PHC. Dear colleagues, let me introduce you to the coalition of countries on PHC. The coalition aims to support a fundamental reorientation of health systems worldwide toward primary health care. The coalition's three key goals include: first, by political mobilization for PHC. We call upon political leaders around the world to demonstrate a consistent commitment to fundamentally reorientating health systems by placing PHC at the forefront of the national health programs. This task will be implemented by A, supporting and holding international events, side events, and sessions during the World Health Assembly, UN UN General Assembly and other international events. And B, participating countries fulfilling the PHC pledge, a promise to transform primary healthcare given in front of their people. Second, policy advocacy for primary healthcare. We will drive policy reforms that prioritize primary healthcare to address systemic challenges and promote sustainable health systems that meet the comprehensive health needs of the population. Our work will launch a global advocacy campaign highlighting the profound political and social benefits of the PHC. This approach aims to raise awareness worldwide and support countries' efforts to prioritize PHC in a national health policy. The third, knowledge exchange on primary healthcare. We will focus on enriching the global discourse on PHC by supporting a series of thematic events and workshops exploring specific areas of PHC transformation, focusing on political commitment, governance, resource, and collaboration. These meetings will serve as the platform for the discussions that promote a deep understanding of critical aspects associated with PHC transformation. The coalition seeks to facilitate knowledge exchange, best practices, and the development of the ideas of a radical reorientation of health systems toward PHC, focusing on the 4 strategic levers of PHC operational framework. The coalition membership model aims to attract a wide range of countries with a common commitment to developing primary health care. The coalition encourages the participants of the countries from different geographic regions that differ in their economic status, the model of the healthcare organization, and other aspects. There are 2 membership options. First is the core group of countries is directly involved in the activities of the coalition, organizing events and information campaigns and participating in quarterly online meetings, supported by the Secretariat and the WHO experts. Second is coalition members committed to a common goal, participate in the coalition annual meeting on the sidelines of the WHA. In this regard, Kazakhstan invites interested countries to participate in coalition of countries on PHC as the core group or a coalition member. The coalition aims to support fundamental reorientation of health systems toward primary healthcare through the practical implementation of PHC operational framework, which in turn will contribute to the development of the primary healthcare capacity in the coalition member countries on the path to achieve WHC and SDG 3 by 2030. We recognize a holistic approach to the organization of primary healthcare includes 3 interrelated elements. First, integrated health services with emphasis on the function of primary healthcare and public health. Second, multi-sectoral policies and actions. And third, empowering people and communities. The coalition serves as an international alliance and partnership platform supported by WHO, ensuring ongoing interaction between partners, sharing knowledge, best practices, and developing ideas. The coalition will establish clear communication channels and interactions among members and other stakeholders. Training and monitoring of coalition activities will be conducted. Detailed information about the coalition is presented in the handouts on your desk. Dear delegates, recognizing that collective efforts can effectively address global health challenges, Kazakhstan calls on countries to join forces to ensure health for all. Thank you for your attention.
Thank you. Thank you very much. This indeed sounds like a really great opportunity for co-creation. And please rest assured that we in WHO, we will take forward the legacy of Professor Sharmanov, and we will keep the flag of the Alma-Ata Declaration high. Now, let's talk a little bit more about this coalition, and I would like to invite my colleague Shem Syed, who is advisor on policy and partnerships, to reflect a little bit what this coalition can do in the already very rich landscape of partnerships to leverage all the evidence that we have heard about today.
Thank you very much, Melita. And first of all, thank you to Your Excellency, the Deputy Minister of Kazakhstan, and appreciating the leadership of Kazakhstan in forging ahead with a country-led coalition. I know time is very short, so I'll just make 3 quick points. So first of all, the word exchange has been mentioned many times this evening. And if you think about the country coalition as it forges ahead, the complementarity between that country coalition and the technical and knowledge products that were being put forward earlier on provides a really interesting connect point. So that's one thing to potentially highlight in any of the exchange that takes place. And that exchange has to also include things that maybe have not worked in different parts of the world. And this is particularly why a country-led coalition can allow that to happen. Second quick point, and this is really directly related to the partnership landscape question that you posed, Melita. Of course, yes, there is a crowded partnership landscape. I think we have to be quite open and honest about that. But we also need to understand the assets that we have. For example, the UHC partnership has been mentioned many times already. It's a huge asset that we need to build on across the world. The PHC accelerator of the Global Action Plan for SDG 3, I'm sure Helga will speak to that, but that's an important part of that landscape. And thirdly, and perhaps more importantly than the first 2, are the regional initiatives that are being taken forward. We know, and we've heard directly from senior leadership at each of the 3 regional offices today, that there's a huge regional momentum that we need to be able to bring into the fold as part of this country-led coalition. And as Dr. Soraya mentioned right at the beginning, the partnership landscape is all about people. So this comes back to the interface of people working with people. The third and final point, I wanted to come back to Bruce's point related to the fragmentation of this world. A country coalition on primary healthcare has an opportunity to unite. And Hannah, you specifically mentioned the issues around peace building. I think this is a hugely important opportunity to build peace through primary healthcare. Thank you.
Thank you very much. And what impressive timekeeping too. We're really running behind time. And I am honored to introduce Helga Fogstad, Director of Health of UNICEF, to round up this really interesting panel. And let's continue perhaps with this theme of partnerships, right? We are working together as partners, WHO and UNICEF, in a historical partnership in strengthening primary healthcare. And we're working together with other United Nations organizations. And yet UNICEF really manages to make an impact at the community level. Can you bring this all together for us and how you see our abilities to leverage these partnerships and the evidence we presented today?
Yeah, thank you so much, and greetings to all. I think you will remember the passion of Alma-Ata. This was is something that is really true to all of us. And the only thing that we came out as a lesson learned from Alma-Ata was that there wasn't enough evidence, and there wasn't enough tools, there wasn't enough consensus. And this took us then from Astana. And in Astana, and ever since Astana, WHO has not only brought 70 authors together, but they have brought hundreds of WHO collaborating centers, academic institutions, and built consensus on evidence, because we did not have that before. And we did not have evidence, or we did not have a consensus on the monitoring and also the data. And so all of that WHO has been able to do. And if you see the rich tools and evidence that are actually available today, equips us very well to take any kind of challenge forward. And what also the evidence shows is that there's a $45 return on investment on PHC. So why aren't we not doing this? Why isn't there enough commitment on implementing this? We have 59 countries that will not reach the MDG target on maternal mortality. We have 64 that will not reach the target on newborn mortality. And yet these are the tools. They provide not only the evidence of the interventions, but also models of care and also rich country experience. So why is that the case? The case is because maternal mortality is not a priority. It has to be declared. It has to be declared an emergency in countries. In these 59 countries, in these 64 countries, it has to be declared an emergency, because then it receives the rightful focus on it. Now, even though it has a return on investment that is very high, impressively high, it still costs money. And that then brings us back to what is it that we start with? And the truth of the matter is that the change has to happen in communities. Closest to the women, closest to the children, closest to the patients, closest to the clients. And so therefore the community health needs to be addressed. And this is where WHO, UNICEF, and the World Bank can be assistful. And this will not be solved without partners. The professional associations have a role, the academia has a role, and the private sector has a role. And it is up to us to find cost-effective interventions of innovation that can actually bend the curve. What is innovations that are proven to be evidence and that are ready to be scaled up and can actually give us more for less money and actually reach better quality. So this is the kind of partnership that we need and enable. And UNICEF, and I think you have seen the impressive line of WHO at both regional and global level, and also the bank stand ready to help in those 59 countries, in the 64 countries. And we need to do this together, and that's at the community. And the community healthcare worker and the link to the rest of the system is important. And there is ample evidence and experience that this has happened and this has been made possible in very few number of years. So feel inspired and feel really good about being a part of this solution, because I think that this is possible. And what we have achieved in 30 years, we have 6 years to achieve a further reduction of 50%. So please feel united and make use of these excellent efforts that WHO has put forward. And we at UNICEF stand ready to help too. Thank you.
Fantastic. Thank you very much. I think this is a perfect end to this very rich panel. It's a call to action. Let us all feel responsible for using this evidence and leveraging it for change. And let us always think of the front line, the communities and the health workers who are making this change happen. Thank you very much. And I pass over for the third segment to Dr. Joseph Figueras and Natasha Soparti-Muscat, who will guide us through our third panel.
Can I ask, please, the panelists, actually, Minister Garcia, can you come back, please? And Karina Rando, Minister Rando, please, as well. And Dr. Abdulaziz to join as well. We'll be introducing you as we ask you questions. Welcome. Okay, the first thing is we're running rather late, and we're all looking forward to the reception. But we have one final panel, which I think you're going to have fun with it. We had fun preparing it. So we heard about evidence, we heard about partnerships, we heard about the support we provide to member states, but what member states want further as we go into transforming the health system, primary healthcare, what are the kinds of priorities they are pursuing, and how together we can work together in learning from each other, and for WHO to support these priorities that our member states are putting on the table. So we cheated a bit, we asked them to, and their cabinets, to give us 3 priority areas, and then Natasha and I put them together into 4 blocks. And gosh, isn't that special, actually? I feel like in a summer storm, you know, with a party. Now I would like to have some boleros, start dancing a bit, but I think we have to wait for the bolero, right? So we grouped them in 4 areas. New roles for primary healthcare and the skills required. There are many challenges there, emergencies, the COVID, mental health, many challenges. What kind of primary healthcare we need? What kind of new skills we need? That's the first block. The second block is the usual suspect, the one we talk a lot, but still we need to do far more, which is workforce retention and motivation, not only recruitment, not only reskilling, but retention and motivation. The third is the access to primary healthcare, particularly in rural areas with the medical deserts. And the last one, we like to wrap it together about showing the value of primary healthcare and its attractiveness. Ultimately, we need to demonstrate that primary healthcare is value for money, and we need to make it attractive to the population. We talked about attractive to those working there, being motivated, but also attractive to the users. So, by the way, my name is Joseph Figueras. I'm the director of the observatory, just in case. And I'm very glad to be accompanied by my very good friend, Natasha, who will introduce herself.
Thank you very much, Josep. Good evening, everyone. Yes, I'm Natasha Tsopardi-Muscat, and I'm the Director for Country Health Systems and Policies at the WHO Regional Office in Europe. And yes, I guess the heavy rain is not going to make you in a hurry to want to leave. And that's just one example of the crisis that we are facing, that primary healthcare is increasingly going to be at the forefront of dealing with climate emergencies. But we were talking a lot about primary healthcare during the COVID pandemic and other emergencies that are taking place. I think we heard also from Rana and other speakers early on about mass displacement of people, conflict, and really our frontline services. So without further ado, I would like to introduce our first speaker, Dr. Mohamed Abdulaziz, who is the head of the African Centers for Disease Control. So could you share with us, from your perspective, how is primary healthcare in the African region actually responding to emergencies? And what is this role that primary healthcare is taking up now more and more as being a point of care and support during these myriad emergencies? And thank you for joining us this evening.
Thank you so much. I'm actually the head of disease control and prevention at the Africa CDC, where community health and primary healthcare is situated right now. And thank you for such an interesting question. Sitting down there, listening to the discussion from the different countries is quite interesting. Listening to Spain talking about how they've used PHC to achieve a lot. These are some of the things we are trying to do at the Africa, support our member state at the Africa CDC to do. Now, if you look at when we talk about health security, people forget that it's a workforce that is responding to HIV, TB, malaria. That's the endemic diseases, and non-communicable disease, mental health. That in times of national emergency, we want to switch to respond to health emergencies. And for the African continent, because of obviously the number of professionals in that workforce is not as much as in other countries. And because many of them are leaving Africa for greener pastures, we know that the most sustainable health system for the continent is the community health workers. And investing in improving the institutionalizing community health workers into PHC, making them a standardized health workforce that can take care of both the universal health coverage, health equity component, and also the emergency component for health. So we in Africa CDC are working to support our member states in that area with different partners. Obviously, we have the Continental Coordination Mechanism, working very closely with other partners on the CHDP to support our member state in getting community health system strengthened and able to respond to both health emergency and at the same time increase coverage when it comes to treatment. And we have one of the lowest coverage for universal health coverage, covering the essential, the different diseases that is afflicting the continent. Thank you.
Thank you very much. And I think there's a very clear point to be made here, which is that we need to be continuing to provide services for HIV, TB, for non-communicable diseases, whilst responding to all the crises. And that when we are talking about who this primary health care workforce who's going to be capable of doing these things, we need to really think of everyone, including as you are doing in Africa with the community workers. Let me come to another area where, at least in the European region, our experience is that one of the new roles or newer roles or more important roles, because it's not new as such, but let's say there's a newfound recognition that we want primary healthcare to be taking on increasingly, is mental health. And of course, this is now becoming part and parcel of most primary healthcare consultations, and we cannot really separate physical health problems from mental health problems. And it is my pleasure now to introduce Minister Karina Rando, Minister of Public Health from Uruguay. And I know, Minister Rando, that this is a topic which is very close to your heart. How do we introduce the new skills, competencies, and roles for mental health in primary care? So perhaps you would like to share with us how you are rising to this challenge in Uruguay.
Thank you. Can you hear me now? Yes. Okay, I'm sorry. Thank you very much for the question, and thank you for the organizers. I'm honored to be here. I will try to quickly share with you the story of Uruguay. Uruguay have a new pandemic that is mental health problem. We have one of the highest rate of suicide in the world, the third or second in America. And that is really a problem. As you said, we said previously, you have to plan, have the resources, and then do. That's what we have done with our president. When I assume as a minister, we talk about this and we said we have to do something. Well, in the last year, what we did is most of the resources for the new year were all driven to mental health. And we have $6 million for mental health in the Ministry of Health after talking this with the president. So he was convinced, and now we are developing this huge program of mental health, and which is our main point of this mental health. We are training general physicians and family doctors in those diseases that can be treated by them. So we are improving primary health care for mental health. And that led us that the psychiatrics, that are very scarce resources, can be led for other people who really need it. And we are now at this moment training more than hundreds and hundreds of GP, emergencies, and family doctors of how to use antidepressants, how to treat depression, anxiety, and also another things in primary health care are being improving. For example, Now the antidepressants can be prescribed by the GP, and they are free for all the population of the public sector, and with a very, very low copayment for the private sector. Both private and public sectors are working together, and we are really, really including the community in the primary health care. We are working with gatekeepers and with these primary healthcare doctors to try to do our best in this pandemic that we have of mental health in Uruguay.
Thank you very much. And thank you for sharing really these commendable activities and actions that you are taking. Let's not forget that health is about physical health, mental health, and also, as our DG said today, the social aspects too, and you highlighted the importance of the community involvement. Minister Garcia, I'm not going to introduce you, you've been introduced already, but perhaps what I would like to ask you, I know that you are paying a lot of attention to the issues around skill mix, around roles, and seeing what roles we have, and really whether every professional, every worker is being utilized to their full potential, and how we ensure that they come together as a team to take up the new roles without fragmentation, without duplication. This is not an easy situation, but I know that in Spain you are determined to tackle this. So perhaps you can share with us what you are doing.
I think that if we had to design our primary care model again today, we would change some elements because we have learned through the experience. We need to reform for the primary care model on the coming years. For example, in our model, the figure of the physician is central to the functioning of primary care centers. However, other healthcare professionals operating at this level have been acquiring more experience in the last years, which will allow us to reorganize the functions. So we need to rethink the roles of all healthcare professionals working in primary care healthcare, and we need to work to enhance this skill mix in primary healthcare, considering, for instance, the role of nurses in drug prescribing or the administrative staff in improving the management of waiting list and reducing the bureaucratic burden. We need to rethink our primary care system as a multidisciplinary one, and we aim to work as an ecosystem. These synergies between primary healthcare professionals will enable to better distribution all the functions and improve the functioning of the healthcare system.
Thank you very much. And I think this takes us very nicely to our next segment, because by giving professionals these new and expanded roles, we are not only being efficient, but we are also working to motivate our professionals. So I hand over to you, Josep, now to take us to the second segment.
Exactly. We heard about the new skills required, the new challenges, and it's all about motivating and retaining, Minister Garcia. Another issue we were debating with you recently, how do we motivate? How do we retain? We have these 3 R's, don't we? The recruitment, the reskilling, we've been listening and retraining, but also the retention and motivation. And Spain has had major strides in that area, as well as some challenges. We're talking recently about filling all the training positions for primary healthcare, family physicians, as well as retaining them in primary healthcare. Can you give us a sense of the challenges as well as some of the policies that you're putting in place, Mr. Garcia?
Of course. The need for more primary healthcare workers is a problem shared by different countries around the world. We often say that the primary care is the gateway to the health system, but for us, it's the heart of the health system. And the heart can hardly function if we cannot rely on one of the key elements that drives it and enables the care of the population, which is the health workforce. In Spain, we have studied the needs of doctors in the healthcare system, and this analysis have shown that we would probably face a deficit in primary care if we didn't implement measures. In recent years, the Ministry of Health has increased the number of places of for medical students to train as primary healthcare specialists, thus increasing the number of professionals in this level, but this is not enough. However, we also need to improve the working conditions of primary care professionals, not only to recruit them, but also to retain them. That's why we are working to change, to improve the working conditions of primary care health system workers, reinforcing the idea of retaining, then recruiting. First retaining, then recruiting. We want primary healthcare professionals to stay in the system because they feel cared for by the institutions, not because there are not better alternatives.
Excellent. Is it about money, Mr. Garcia? Is it money? Is it quality? Is quality of work? Is it training opportunities? Or probably all of the above, right?
All of them, of course.
All of them, indeed. Mr. Timur Sultan Gaziev, Kazakhstan has been worrying and looking at this issue and putting a series of policies as well to motivate the doctors and nurses. Let's not forget, this is not about doctors, it's about nursing, it's about auxiliary professionals, it's about all this skill mix that you both, the ministers, were highlighting earlier. So how do we motivate this healthcare workforce in primary healthcare? How do you do that in Kazakhstan?
Thank you very much for the question. This is a really important question. In our country, we just recently passed new legislation increasing the status of all the healthcare workers, including the physicians and nurses and all the medical personnel who is working at the primary healthcare level. And this is the first thing needs to be the realization from the political leaders and promoting through the status of the medical workers through the proper legislation. And through that legislation, we also included additional monetary motivation for our personnel. First of all, talking about especially at the rural areas.
So you give it more status to professionals.
Absolutely, especially for the rural areas, we increased, we first time put so-called motivational, encouragement. It's around $20,000 per young physician going to the rural area, which is quite good in the beginning of the career. Also, we implement social additional support as housing, other supports. Another thing was just, again, talking about the monetary motivation, just starting from 2020, we've been increasing the salaries of all the physicians by 30% each year. And for the nurses, for the 20% each year. So
there's money. Are there any other incentives?
Yeah, I was talking about the, of course, it's environment, it's the conditions of the working conditions of the healthcare personnel, as well as the workload and managing that workload and developing the additional skills necessary for the primary healthcare workers through training and etc. Thank you.
Excellent. Natasha, that links beautifully well, almost as we had planned with the issues of access and rural areas, actually.
Yes, I hardly even need to segue because I think Dr. Sultan Gaziev has provided a very clear narrative around retention, particularly, and attraction in the rural areas. And this is something we are all struggling with, particularly because we see that the primary healthcare workforce in rural areas in many countries is the fastest aging workforce and the one that is most difficult to replace. This is not just a healthcare issue. This is actually a rural development issue, and it is an issue that is really challenging our policymakers. I come to you again, Minister Rando, because I know that in Uruguay you are also facing the issue of the so-called healthcare deserts. And perhaps you can share with us how you are also trying to address this very complex problem.
Yes, thank you for the question. Exactly. Uruguay has most of the people live in cities, but the few people who live in rural areas usually does not have doctors in that areas. And what happened is that all doctors have retired, and then it's very difficult to bring young new doctors to those areas. So what we have done is we make a survey and we try to analyze and talk with the doctors and see why and what do they want. And we were very surprised because the first thing that the new doctors, the young doctors told us is that in rural areas, they don't have, for example, schools to grow up their kids or entertainment for the weekend, or for example, a gym to do exercises. So that is very difficult because you're not going to put a school in every town with 200 people. And so that's a problem. The other problem that they saw was that when they have patients that are critical, sometimes it's difficult to transport them and to send them to hospitals. So what we have done is we put ambulances. So then the new doctors can work more comfortable, that if they need another level of care, they will be able to take the patient. Then the other is, of course, the payment. That is easy. We try to pay more, but that does not make, it was not very related. We double the salary, and even though they say no. And the other is that we are incentive recertification, for example, and they said that in rural areas, they do not have the opportunity to train themselves. So as they cannot train themselves, they cannot recertificate. So we are improving the way of certificate using remote distance learning. So we are trying to do that in our rural areas. That's our experience.
Thank you for breaking this down in a very, very authentic manner. In fact, it relates perfectly to what we have been hearing, for example, from the European Young Doctors Association. And I think the most telling point is that money alone is not going to help us to solve this problem. Dr. Sultan Gaziev, you were already alluding to some of the issues that you are trying to tackle in terms of the workforce. But let's come now to the model of care in Kazakhstan. Kazakhstan is a huge, beautiful country with many people living in rural areas. I remember seeing that video of the train that goes around delivering care. But perhaps if you can just, in a couple of minutes, help us imagine, when we talk about rural primary healthcare in Kazakhstan, what are we talking about? What services do you deliver and how do you deliver them?
Thank you for the question. Kazakhstan is a huge country, ninth largest country in the world, but sparsely populated. Only 20 million people live there, and 37% of the population live at the rural areas. And the major thing is to have in place proper infrastructure facilities. So in order to do that, last year we started a national project, modernization of rural healthcare. So we started to renovate or build where it's absent, the new facilities, new infrastructure for the distant rural areas. And the second part is, of course, is attract and retain the professionals. So in that national project, the second big block of the priorities is to attract the physicians and nurses to the rural areas. So in order to give better healthcare at the rural areas, considering that there's a huge difference in the equipment, infrastructure, and etc. We started to run the trains that you just mentioned, 2 trains that go around all year long throughout all the different regions of Kazakhstan, which are that trains equipped with all the necessary equipments, X-rays, mammography, ECG, laboratories, and with necessary professionals. And in addition to that, we have so-called mobile medical complexes. So it's just a huge bus that goes around to different small towns and provide all the necessary healthcare services. And we have around 150 of them right now running around the country. So also the other very important parts is the telemedicine. In all the new healthcare facilities and old healthcare facilities, we're introducing the telemedical services. So the patient will be having direct contact with the GP, or if necessary, the specialist, to have necessary the consultation services.
Thank you very much. And I think basically we're hearing that the healthcare infrastructure in primary care cannot be inferior if we want people to really believe that we are serious about primary care. And also that today, all primary healthcare centers, particularly those that are most distant, need to be networked and linked digitally. And I think this comes very nicely to the last part of our discussion today, because it's all of this that then finally makes patients, I guess, trust primary healthcare more.
Exactly. The last block, and probably the most important of the 4 blocks, is to demonstrate the value of primary health care and make it attractive to the population as well as to the Minister of Finance. There's ample evidence, and the volume, this is just a summary that our colleagues have put together, synthesizes all this evidence on the efficiency, on the value for money, on the responsiveness, on the access that primary healthcare is providing. And yet, we're not quite managing. It is still perceived in many of our countries as poor medicine for the poor, poor primary healthcare for the poor. Still in many countries, specialized care is perceived as of higher quality. And indeed, that trust, Regional Director Hans Kluger, that was at the core of the ministerial conference, how to regain that trust when it's lost, or gain it when it's not there. So all of you, in many ways, have brought that element of value and trust and attractiveness of primary health care. So we'll make it the last wrap up here. Let me start with Minister Rando from Uruguay. Why is it so difficult? And what do we do about that, to get that trust, to get that understanding?
It's really very difficult. What happens, sometimes we are always thinking in the point of view of the doctors, and sometimes we have to go back and see the point of view of the patient. What happened in our country, I don't know if it is all around the world the same, but the GP, the general practitioner, does not have so much prestigious as a cardiologist, an anesthesiologist, a surgeon. So if there is a problem on the throat, of the throat, for example, they go to otorhinolaryngologist instead of going to the GP. And if you refer them to a GP, probably they will complain and they go to another. So one of the things we are trying to do is to giving importance and make the population feel how valuable it is to have a general practitioner and a family doctor, because the family doctor is not going to go so in deep in one disease, but the family doctor is going to view the whole component of the health of that patient and that family. So we're trying to change the mind of the patient. That is one of the things. And then I know we're short of time, but only one thing that is important. The other problem is that sometimes in the clinics, the patients do not have the medication. So anyway, they have to go to the hospital because they see the GP or the family doctor, and then they have to go to the hospital to have the medication. So they say, well, let's go to the hospital, consult in the emergency, and then I will have everything there. So what we are doing, the electronic prescription that is now available in every pharmacy, in every neighborhood. So the population can go with their identity card and said, I have this medication prescribed, and the pharmacy will give it because it's in all the pharmacies of the country. So that may help to improve and encourage people to go to the GP first and not to the specialist.
That's very helpful. And perhaps it's one area that if we have a tiny bit of time, and then we'd like to hear more from colleagues also and experts here in the audience today. We talked about making primary healthcare attractive, and we talked about what are those aspects of primary healthcare that show value in particular. Vice Minister Sultan Gaziev, what would be the two aspects of the primary healthcare model in Kazakhstan? We heard about your leadership, both in Alma-Ata Declaration and then in Astana Declaration, and you very much built a health system, like all of you actually have here 3 countries that are the full front of primary healthcare reforms. Very, very good examples, good illustrations. If you had to choose 2 aspects of your primary healthcare system that you believe are particularly value for money, value in terms of impact, that you can go to your Minister of Finance and make a case, what would be these 2 areas you put on the table?
Thank you for the question. Together with Regional Director Dr. Hans, a couple of years ago, we opened up the demonstration platform in Kazakhstan. And that platform, the major point is to share the experience, especially of the multidisciplinary teams. So that would be the major aspect of the primary health care is the multidisciplinary team, where in the center is the general practitioner with nurses. We have 3 nurses for 1 general practitioner, helping with the social worker, psychologist, and if necessary, the specialist.
So you're demonstrating that this mix is far more cost-effective than having GPs and nurses traditional system alone.
Absolutely.
Thank you. Minister Garcia, there were 2 aspects. We're having this debate the other day that you particularly believe. I like very much, by the way, it reaches my heart when you say that primary healthcare is not the entry point, it's the heart of a health system. And then I dare to say that and the health workers and the population are the blood of the system. What are those aspects in primary healthcare that when you go to your Minister of Finance, when you go to the population, you want to put forward? We heard from Kazakhstan was multidisciplinarity. What would be the 2 aspects you would put from Spain?
Okay, the Minister of Uruguay say that prestige of cardiologists and anesthesiologists, because we are both anesthesiologists. So if we need to improve primary care, we need to focus in one thing that it's very important, the continuity and the longitudinality care, the longitudinality. No? If we had a drug that could reduce emergency visits, hospital admissions, and mortality, we wouldn't hesitate to incorporate into our healthcare system, no? So we have this drug. This drug is primary care and longitudinality. It has, we have all the evidence to know that the longitudinality, the stability for our professionals, the care guarantee for our patients reduce the emergency visits, the hospital admissions, and the mortality. So we have to use it. No, we have to invest in primary care, in the time of the practitioners, in the doctors, and we have to improve the working conditions of the healthcare workers. And in addition, the Ministry of Health has made significant investments in new digital technologies and innovation for primary care services. We need to look at the intelligent artificial as a tool to facilitate our work in the primary care and to facilitate to work and enhance their relationship with the patients, no? Not as a barrier, but as a tool to facilitate our practice.
Excellent. Thank you very much. Indeed, for that continuity of care, that integrated care, we need to enable with the skill mix. And indeed, thank you for bringing an area we're hoping, we're discussing that, right, Natasha, the digital instruments to be able, e-health records, to be able to have this integrated care that is so important. I will now give you, Dr. Abdulaziz, the last word in this, before we go to our colleagues that are joining us, also many experts. What's your reflection from your continent, from Africa, into demonstrating that value of primary healthcare and making it attractive? Because even in parts of Africa, people actually bypass primary care because it's perceived of low quality and try to queue into hospitals, right?
Yeah, but the most important thing is the value the consumers of the PHC services get from what kind of services, the integrated services that you're putting in place in the PHC. Mostly it's viewed like the services at the PHC is inferior to what you see in other places, but there is one example, and I'm going to cite this example here. When it comes to immunization, actually, people in many African countries are now beginning to see that the best quality immunizations you get from the PHC facilities. Yeah. So you see doctors in tertiary institutions taking their children to the PHC instead of private hospitals or even in their tertiary hospital, because when you go to the PHCs, you see solar fridges, you see excellent cold chain, you see partners have supported the delivery of immunizations. And personally, all my children have vaccinated them at the PHC. This even before I joined public health. I'm a clinician like you. So, but this is the value with which people in the community takes when they see quality services. So the onus lies on us to make those services quality, not just the quantity, but the quality of the services that we give there. Once people see the value, they will not travel 200 kilometers, spending half of their monthly salary when there's something available on ground. Finally, let me also say this example. For the government in Africa, using primary healthcare workers, community health workers, maybe even for the COVID-19 pandemic, where I've seen in an African country, initially, they were sending epidemiologists, giving them 3,000 USD to respond to the COVID-19 outbreak. But when it became protracted, they opted to use community health workers. And these community health workers, because they are trusted members of the community, they could go into the family evening home, they could convince people to take vaccination, risk communication, getting data. They perform much better than even epidemiologists that were sent. And then the country was able to scale up the services because community health workers are much cheaper than epidemiologists. So those two areas, you have to look at it critically. Importantly, we have to ensure that the quality of the services that is given at the PHC is not inferior. If people get that, they understand, then you will see them choosing that instead of going many kilometers away to access other care. Thank you.
Thank you very, very much indeed. Maybe we see the eradication, one of the oldest diseases in the health system, which is from verticality to horizontality. Maybe these comments make us believe that we can integrate all these services that we used to provide vertically, because many of the donors, by the way, are now integrated into primary healthcare. This is very good news. Natasha, want to wrap us up or open the debate rather?
Thank you. I mean, I think our panel really deserves a round of applause
Indeed.
for being so genuine and so brilliant. And the take-home messages are crystal clear. It needs to be good quality. It needs to be what people want, and they will come. So hopefully we will not have to write another editorial about the political dichotomy and this gap between what we know is right and is not happening. Before opening, perhaps we can take 3-4 reflections from the floor. We have also had the Minister of Health of Slovenia, De Valentina, sitting patiently and listening. And I was wondering whether perhaps you would like to make a couple of reflections. We are working also very closely with Slovenia, champion of primary healthcare.
Well, yes, thank you very much. So I was quite amazed by this debate, very productive, very nice. And I want to tell you why. Because I am so lucky that I was actually born in a country with a strong primary health care. Primary health care has a strong and long tradition in Slovenia, and I cannot imagine living in a country without primary health care. I was wondering how to demonstrate this to you. So maybe like this. I've been in this world for over half a century, and my mom has been a family physician for all her career. And now you must believe me that my mom is older than me. So anyhow, primary health care has been changing also in Slovenia. It's been very successful, very good, very accessible, but the demand has been increasing, and so has the expectations of people, because they like going to primary care. It's gatekeeping, it's their first touch with the physician. So, you know, in time, we have to change things. The integrated care is coming, continuity care is important, competencies are changing. And also with the help of WHO based, they supported an analysis of primary healthcare sector. We are building a new strategy for primary healthcare with more emphasis on quality of care, quality indicators, digitalization, competencies, and so on. But the emphasis will remain on the community approach and on person-centered care. And since Josep asked previously about what people think, what is the best investment, I think the investment which has the biggest value for money, which is this technology, and I'm an economist, I'm not an anesthesiologist, so from this point of view as well, is investment in prevention. Thank you.
Thank you.
Thank you. Thank you. We also got the element of prevention in. I know that we're really standing between the reception. We've already abused, I think, around 15 minutes over and above. But perhaps, Josep, can we take 1 or 2
Yes,
reflections?
we are going to round and take it away if you talk too much, but we like some additional contributions, please. Very short. Yes.
Good evening. My name is Anna Stavdal. I'm a family doctor from Oslo, Norway, and also the immediate past president of the World Organization of Family Doctors. First of all, thank you for this event. And I will especially commend the ministers on stage. I've never heard this level of insight in understanding generalism, which is the key word here. In my work as president for this very diverse crowd, the World Organization of Family Doctors, I found one sentence to amalgamate this crowd into one identity, and that is, we provide trust enabled by continuity of care. Thank you very much.
A very beautiful way to wrap it up. Thank you. Thank you very much. Are there any other? Yes, please.
Thank you. And I dare to promise to be short. Milka Sokolovic from IFA, the European Public Health Alliance. I would just like to, well, first of all, thank you. Fantastic whole session today and a fantastic closing panel. I would just like to build on with one sentence on what the Slovenian Minister of Health said. Back to prevention. I think that the primary health care needs to become a continuum with public health. There is no proper primary, or the primary healthcare will be more expensive if there is no more investment into promotion and prevention.
And the volume has many, many good practices, starting with Slovenia. And we heard from the minister already about the integration of primary healthcare, public health into primary healthcare.
Thank you, Natasha. My name is Marat Shuranov. I'm from Kazakhstan, but I would like to add some, short comment in terms of the second session, second segment. For the almost half of century, the Alma-Ata Declaration hasn't achieved its objectives totally around the world. It seems like 15 years ago, we adopted this declaration, and each country was dealing with this declaration by themselves. So that is why I strongly believe that the initiative of the building of the coalition on primary healthcare should bring us all together. And as for the half of the century, all the issues are still crucial. I strongly believe that that's going to be a new page in a history when we will speed up and make this health for all. Thank you.
Thank you very much. And I don't see any other hands. There's one here. Okay, we take the last one, Joseph, over here.
Thank you so much. Dalia from Federal Ministry of Health, Sudan. I'm very glad that I had this opportunity to, I was amazed with all of the interventions. Maybe I have a question that all of the retentions solutions, it's not fit with the very limited resource settings and with very emergency settings. Sudan now with this huge crisis and with 72 medical schools graduating each year, medicals, doctors and nurses just crossing the sea to the Gulf countries.
Yeah.
What will be the solution for such kind of setting and how we can retain those healthcare workforce and to be embedded in system for the emergency response in a very government low wages, like now the shifting of the priorities to the military actions and so on. So I think we need to customize those solutions to this kind of fragility. I think those very fragile countries need contextualized solution. Thank you so much.
Thank you so much. And I think it's fair to say that this is really one of the biggest problems and challenges that we are dealing with globally. Just to remind people also that there is the work taking place on the code, but also the fact that we do know that the only way we are going to manage to do everything that we were told that we want to be doing in primary healthcare, given the global shortages of health workers, given also the growing needs and opportunities that healthcare is providing to save lives and to have better quality of life, is to transform our health systems. And I think this brings us back to the very fact that we know that investing and building on a bedrock of primary health is part of this solution. So I think we can stop here, Joseph. Thank you very much to everyone, to the observatory, to our GDO in Almaty, to our colleagues in HQ who have really been leading all of this. We are just here to support. And I've probably left many people out. So I
We'd like to thank as well the 400 people actually on average that have been following us. Thank you very much.